Thank you very much, the University Choir. And good afternoon, ladies and gentlemen. Shall we kindly rise for a word of prayer as I invite Dr. Teresa Edu, the University Librarian, to lead us with a word of prayer.
Shall we pray? We are grateful to you this morning, Lord, afternoon, for traveling mercies, bringing each one from our various homes to this place, and to participate in this very important leadership lecture series in memory of our former president, our late President, Professor John Evans Atta-Mills. We pray that, Lord, you will take absolute control over the whole program. And at the end of it all, give us lessons that would help us as individuals, as an institution, and as a nation. We bless you that you have taken your rightful position amongst us in Jesus' mighty name. Amen. Amen. Thank you.
Kindly take your seats. The chairman of the University Council, Professor Kojo Gavois, members of the University Council, our foundation chairman of council, Professor Kofi Anyidoho, our foundation vice chancellor, who thankfully and graciously is now a member of the University Council, Professor Fred Newton Binker, senior management of the University of Health and Allied Sciences, distinguished guest speaker, who also happens to be one-time member of the interim council of this noble university, became a member of the first regular council of this university, Dr. Soji Tete, and your wife, Na, you're welcome. I don't see my Tobio and Mamao, they are coming. Members of convocation, distinguished guests, deans, directors, our friends from the media, our students, ladies and gentlemen, good afternoon once again. I also acknowledge the presence of one of our former council members, Dr. Mark Ameo. Doctor, thank you for joining us. It is my absolute pleasure this afternoon to welcome you to the City Auditorium of the University of Health and Allied Sciences. To those visiting us for the first time, we pride ourselves as the only university in Ghana dedicated solely for the training of health professionals. Now, by kind courtesy of the Chinese government, together with facilitation of the Ghana government, we have one of the most beautiful central administration and schools of nursing and midwifery and a simulation center in the whole of West Africa. And so you are warmly welcome to US. We also pride ourselves, calling ourselves the great giant rising. Indeed, if you have been following our story, you would reckon and agree with me that we are great giant rising, soon to overtake the premiers. Distinguished ladies and gentlemen, this afternoon we are gathered here for the John Evans Atta-Mills Leadership Lecture. Our chairperson for this afternoon's occasion is none other than our Prof. One, as we affectionately call her, She is Professor Lydia Aziato, the first female Vice Chancellor of the University of Health and Allied Sciences. It is both my singular honor to invite her to the stage as she welcomes you again and introduces the guest speaker for today. Thank you very much.
Good afternoon. Oh, I can feel the vibe. Good afternoon. ICT, can you give me a hand, please? Okay. Thank you very much, ICT team. This afternoon is a pleasure, it's an honor and a privilege. I took office almost 3 years ago, and the previous 2 lectures were chaired by my council chairman. Traditions are that the Vice Chancellor chairs the lecture. I preferred my council chairman to chair. However, my new council was just inaugurated a few days ago. So, Professor Gabwa, let me chair this one next time. I'll let you chair. I prefer my council chairman to chair my lectures. So this afternoon, we are here gathered to learn from our distinguished lecturer. We will have opportunity to ask questions. We will have opportunity for him to share further insights into his thoughts and experiences over the years. I graciously agree to chair this function. I have to introduce him to you. Mr. Speaker, our students are now reporting to school, so majority of them are not yet here. We bring in other schools. They are also writing some interim exams. So forgive us that the audience is the way it is. I'm sure that some will join after their exam. So before I introduce the chair, the speaker, I need to let us know why this lecture was instituted and why we named it after our late president. So this is the 9th of this lecture, and we are happy that our own Dr. Soji Tete is the speaker today. I also want to thank Council, the chair specifically, for giving administrative approval for the lecturer. So usually here in this university, after academic board approval, Council gives its blessing for the lecturer. So our late president, Professor John Evans Fifi Atta-Mills, was the 3rd president of the 4th Republic, and he led this nation from 2009 to 2012. But before then, he was our 2nd man of the country, the Vice President of Ghana, from 1997 to 2001. That is when I finished university, my first degree, many, many years ago. He was our Vice President. Our late president hails from the central region of Ghana, and he was born on July 21, 1944, and he passed to glory in July again, 24, 2012. May his soul rest in peace. Our late president attended Atta-Mills School. He continued to the University of Ghana, and he also went to London School of Economics, and he became a lawyer. After some years of practice, he did his PhD and joined academia. So he overall had 25 years working as an academic before he went into mainstream politics. When he became a lecturer, he worked hard and attained associate professor status at the Faculty of Law in the University of Ghana, where he worked over the period of 25 years. During my readings, I found that our late president was a sportsman, and he loved hockey, and his favorite team was Accra Hearts of Oak. But I am a phobia, no, the Kotoko. Kotoko is which one? Fabulous. So my brothers, my senior most brother, late senior most brother, was a die-hard phobia, and I decided to, just make him angry. So I decided to be a Kotoko fan. I don't know why. I don't know anybody, but I decided to be a Kotoko fan. Anyway, that's just saying that we love him loving sports. He became a Fulbright scholar at Stanford University School of Law, 1971. Some of us were not born then. And he went to several other international schools, School of Economics. He did short courses. He taught there, gave seminars. He did a lot. US, UK, Canada, and we acknowledge his input. My predecessors made a statement for council approval, giving a justification for naming the lecture, the annual lecture, that culminates into the lecturer being awarded an honorary doctorate, and it was approved. Some of the reasons they gave was that our late president was an astute academic, and he was a statesman that we all admired, and he did his best during his tenure as vice president and as president. We all know that it was through him and his government that UHAS was established. And so this proposal or request was approved, and our annual lecture was named the John Evans Atta-Mills Leadership Lecture Series. So every year, we have an esteemed person coming to give the lecture. So my predecessors, i.e. former vice chancellors, why am I saying vice president? Provinka, maybe I want to make you a vice president. So Provinka set the pace, and then Professor John Japon continued. So far, we've had 8 distinguished people mounting the stage. The first one, in 2016, was Professor Samuel Kofi Sefadede. He was followed by Dr. Dovlo. Dr. Moeti came in, and Professor Molino came in. And then Dr. Anefi also mounted the stage. And then we had a 6th lecturer, Dr. Joseph Siao, Japan. The last 2 lecturers were Professor Ernest Aite, who was a former Vice Chancellor of the University of Ghana, And then last year, we had Reverend Dr. Joyce Ayi also coming to share her thoughts with us. Today, the lens fell on a gentleman that the state has given a huge responsibility to lead the National Vaccine Institute. Like the registrar said, this young man was part of the history of UHAS. He was part of the team that started as interim counsel for the university. I am sure when he takes the stage, he may share a few thoughts regarding that phase of his life. So our distinguished speaker is Dr. Soji Tete. He is a medical doctor, and he did his MPH at the University of Ghana. He also obtained a certificate from the Institute for Healthcare Improvements in the US. He had several fellowships, one of them in healthcare quality and safety, and he was also a Rockefeller Global Fellow. He also had another certificate in health administration and management at GIMPA. There is a favorite or very, very well, should I say, people love going to GIMPA for this program, and he went there in 2016. He has done several leadership courses and programs over time, and he became the vice president for global delivery at the Institute for Healthcare Improvements. I mentioned already that this gentleman, even though he's young, is very, very loaded. He served as an executive director and head of Africa region for the NIH, Institute for Health Improvement, NIH. And he had several opportunities to serve the African continent in many dimensions within this space. Again, he's very experienced in monitoring and evaluation. He's done several work there. But before he rose to the national and international space, he worked as a medical officer at the St. Anthony's Hospital here in the Volta region. But he was also a house officer at the Kolebu Teaching Hospital. He has served on several boards and committees. When you look at the program we have given you, it gives a very detailed profile of our speaker. I entreat you to have a look at it. The program also gives you some abstracts of what he's going to share with us today. So the UHAS Council, Interim Council, he was on from 2012 to 2016. He also belongs to several professional bodies, and the Ghana Medical Association is listed. The evidence of his quality culminated in several awards, and we want to congratulate our speaker for the feats he has achieved thus far, and we want to encourage you to do more for the younger generation to look up to you in the future. Today, our speaker is going to share his thoughts on advancing quality health systems in Ghana amidst global disruptions. I looked at the abstracts and I thought that a few things are important, what we anticipate to hear from him. Over 7 million lives have been claimed by COVID. I nearly died in 2020. I would have been one of them. Over time, people are losing their jobs. A lot of people. I'm sure he will give out the statistics. However, with the dwindling of donor funds, the onus is on our distinguished speaker as a leader of the Vaccine Institute to see how we can develop our own vaccines and prevent diseases. I'm sure he'll say a little about this. He raised some questions in the abstract. How can Ghana take a fresh look at its health system to ensure integration of services focusing on prevention, treatment, and maintenance? How can a strong national direction for achieving quality health systems and improving quality be brought to the fore? We are going to listen to the answers to some of these rhetorical questions, or should I say real questions that he posed. The last one is, can these global disruptions just present new opportunities for greater self-reliance? And this goes to what I said earlier, that dwindling global funding has direct impacts on us as Africans or people from low and middle income countries. So on this note, those at the back, can you move forward as I try to leave the stage? Come join those at the front so that the pictures will look nice. Can you come forward, please? Everybody at the back, come forward before I leave the seat. And those at the corner there, if you are not part of the choir, can you move here, please? Please hurry up because of time. Hurry up. Thank you as you move forward. The choir, can you be giving me some background sound as they move so that the room is a little lively? Thank you very much as you move forward. All right. So the choir is fine. You didn't give me on time. So on this note, I thank you for your attention as we listen to the lecturer. So ICT, before he comes, can you come and mount so that I'll take all the delays. Singular honor to invite to the podium our distinguished speaker, Dr. Sodi Tete.
I would take it that the Vice Chancellor has done all due diligence with acknowledging everybody in the audience, and so I'll stand on that protocol and proceed with my presentation. I want to thank you, Professor Lydia Ziato, for your very kind introduction. In more ways than one, I feel that things have come full circle for me. As a member of the Interim Council, and then later on becoming a full member of the Substantive Council, that instituted this Professor John Evans Atta-Mills Leadership Lecture, it is such an honor to be called to come back and to deliver the lecture. So I'm very grateful to the management, to the council, to the wider university community for this honor done me. The significance of the event is also not lost on me. A few days ago, I heard the announcement of the university going to be renamed or going to be named after Professor John Evans Atta-Mills. So it's quite auspicious that I should be the one to deliver the lecture just when this decision has been taken. So I'm going to tell a story, or a series of stories today. I'm going to talk about the number of people that have helped me to put this together. We'll talk about how we can advance quality health systems in Ghana amidst a lot of disruptions that are happening globally. The ever-present threat of pandemics, the disruptions in global financing, the fact that we have quality of care challenges that continue to exist, how the country intends to achieve vaccine self-sufficiency, and I'll advance some recommendations for how we might think through these challenges, and end with a provocation from our neighbors in Burkina Faso. But first, I'll start with what Ghanaians typically refer to as vote of thanks, because the way in which the speech is going to end, I will not have time to do vote of thanks. I'm starting this way because so many people contributed to putting this presentation together. I couldn't have done it without the support of my friend and brother, Stephen Kemeche, who insisted that for the John Evans Atta-Mills lecture, he needed to create a new PowerPoint slide template. And this was in addition of the extensive research that was also done. I would also have to acknowledge Caroline Akwe-Norte of the National Vaccine Institute, who did an enormous amount of research together with Pearl Ehonam Salome. And then, of course, my one and only Dr. Na Adokos Sojitete, whose rigorous critique and feedback helped to shape the speech. She always thinks I'm going too far, and she wants to rein me in. My former boss, Pierre Baca, from the Institute for Healthcare Improvement in the US, contributed. Then Professor Jeffrey Braithwaite from the Institute for Quality Healthcare and an Australian Quality Institute also helped. And then my mentor, Professor Fred Newton-Binker, and many others, too numerous to list here, are all deeply appreciated. February 2012 came without any clarity as to what we could expect in terms of 6 individuals who were called upon to undertake a national assignment. President Mills had won the 2008 elections, and in the course of the elections, he had promised that he was going to put a health-related university in the Volta region. By 2012, President Mills had been in office for about 3 years, and the promise had not been fulfilled, and we had 10 months to the election. So when Professor Mills selected these 6 individuals to constitute the interim council, he gave us a clear and wicked mandate: admit the first batch of students by September 2012. For me personally, it felt very exciting to be among these accomplished patriots and to be doing important things like interviewing and recruiting the first vice-chancellor, who happened to be my own mentor, Professor Binker. I've been following Professor Binker for years, but as a member of the interim council, I was clearly his boss. That felt very nice. Professor Kofi Anyudohu ensured that the UHAS student will come out as an all-round student. So although science became the foundation for being admitted into UHAS, he insisted that there should be lessons in English and African studies, so that the student that was trained in UHAS will be connected to his or her community and in touch with their culture. Dr. Yawadi Jemfi was bustling with entrepreneurial fervor in terms of his views and how we can make money for the university. Thank you very much. Professor Ernest Ayite, then the Vice-Chancellor of the University of Ghana, generously shared with us from all the rich experiences from the University of Ghana. It was very fascinating to watch him at work on council. Any difficulty that came up, we would say, well, how did Legon handle this? And he would just rattle it all off. Togbi Tekprehodo IV from the Amfoiga area offered pro bono legal services to the university. In addition to that, occasionally he will pull me aside because they all considered me the small boy on the university council and said, Soji, come here. Professor Mills was my lecturer in the law school. I was a student. And there's a reason why Professor Mills selected us to be on this council. We have to get it right. I can assure you that Togbi was a very notorious law student. Brilliant, but notorious. But ladies and gentlemen, I'm acutely aware of whose land I'm standing on today. So I shall defame him no more, lest I'm subjected to punishment. With 10 months to admitting the first batch of students, the reality of not having residential accommodation hit us very hard in the face as an interim council. We all marched to an abandoned hostel as you exit home, identified by the Vice Chancellor and the Registrar. There, we learned that the hostel belonged to the Ministry of Health and therefore could not be available for UHAS. The Interim Council took a somewhat uncompromising position. The Council said that if the uncompleted buildings belong to the Ministry of Health, then they belong to the government of Ghana. And for that reason, we are going to complete the buildings and the students are going to use it for September admissions. Subsequently, we authorized the management to deploy resources in that regard. The rest, as they say, is history. One day, we were touring the incubator facilities that had been put together for the university at the Volta Regional Hospital. The interim council felt that the facilities were woefully inadequate for the vision that President Mills had for the university. And I distinctly recall an interesting statement that was made by Justice Agnes Doji, a justice of the Court of Appeal at the time. She looked at the air conditioner in the room, a small room, and then she said, with a lot of fury, I wish I could rip off that AC from the wall and smash it on the ground, because this is not fit for a university of this caliber. We all burst into laughter, because looking at Justice Georgie's petite frame, smallish, we could not just imagine where she would find the energy from to rip the AC from the wall. These were the Buffalo Soldiers. I can still imagine Professor Benka in shorts on this land that used to be one big bush, saying that they were using dynamite to smash the rocks. Or Professor Benka and his team sitting at the Ministry of Finance for hours, waiting for financial clearance. There were times I know, because I worked quite closely with him, that he resorted to threats. He would go and threaten people at the ministry that you are from the region. If you dare refuse to give us financial clearance, you will see what will happen to you. I remember where I was when I was invited to join the interim council. The call came from Dr. Christina Amakunyama, who is now like a mother figure to me. She was then a presidential advisor and a former minister for environment, science, and technology. I refused to join the council. I said to her that I'm not itching to join the government. If the government does well and the country prospers, it's okay, that's really all that I want. But she said that, look, there's a compelling vision that President Mills has for setting up the university, so you need to think about it. You can't refuse this offer from the president. All right, so let me think about it. And when I get home, I'm going to discuss with my wife, and then I'll give you an answer. By the time I got back home after about an hour, the news was on the airwaves that President Mills had appointed the interim council. This is the first time it dawned on me that when politicians want to move fast, they can really move fast. I was faced with two choices after the announcement was made on the airwaves: whether to join the experienced team that had been assembled to drive this inspiring vision, or to continue my resistance of what would turn out to be my first political appointment. I'm glad I chose the former. Working with the interim council, the vice chancellor and his team was a blessing of a lifetime. I saw firsthand what it takes to build an institution from scratch, the joys and the aches. Today, it is perhaps a design of God that I've been appointed by President John Mahama to head another relatively young institution, the National Vaccine Institute, to spearhead Ghana's local vaccine manufacturing aspirations. My early experiences with UHAS somewhat helped prepare me for my task today, and I have President Mills to thank for that. Professor Mills believed in young people. I was appointed to the interim council at the age of 37, and I remember that he also appointed Honorable Samuel Kujeto, a Deputy Minister for Education, at the age of 28. Honorable Edward Okufio-Mane Boama, another young doctor, as a Deputy Minister of Communication. Today, all of these individuals continue to serve the nation in various capacities. And it was the celebrated lawyer, Chachu Chikata, who first described President Mills as having distinguished himself in his politics with what he called Mills's charisma of integrity. And in an article that I wrote 2 years ago, I said of him that he was neither loud nor manifestly exciting, as charisma is often defined. And yet the sheer force of his character of integrity spoke volumes and influenced so many. So now perhaps I would get into what I suppose you are expecting, quality health systems. And I want to start by laying the foundation in terms of some definitions, what we mean by quality health systems. And there are three organizations that have done a lot of work in this area. We've had the Lancet Global Commission on Quality. We've had the World Health Organization, the World Bank, and the OECD as one cluster, and the National Academy of Sciences, Engineering, and Medicine in the United States. And I feel particularly drawn to the definition by the WHO, primarily because it broadens the span of quality health systems to embrace promotion, prevention, treatment, rehabilitation, and palliation. The WHO defines quality health systems as those systems in which the health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So we use the best evidence base to manage your condition, and we get you better in terms of improving your health outcomes. All of the other definitions agree with this, but there are a couple more additions from the Lancet Global Commission. They said that in addition to getting you better using the best evidence base, these quality health systems are trusted and valued by all people. And also it has a dynamic effect of being able to address changing needs as the population grows. Then, in addition, the National Academy of Sciences, Engineering, and Medicine says that the people and the populations being overseen by these quality health systems, when they face health threats, they should not suffer financial hardship. In other words, when you fall ill, when you have an illness episode and you are managed, the cost of being treated should not take into financial hardship, what the health economics refer to as catastrophic health expenditure. So overall, the following features of a quality health system must endure. You must improve your health outcomes, including delivering care that is safe, that is effective, that is patient-centered, that is timely, and all the other attributes of quality that we talk about. 2, it must be evidence-based. It should not be a matter of opinion. We should have the scientific basis for treating you. 3, it must be trusted by the people. 4, it should be able to protect you from all the health threats, including the pandemics. And 5, it should save you from financial hardships. How then are recent disruptions in global health financing threatening quality health systems? In February 2025, US President Donald Trump signed an executive order. It was called Reevaluating and Realigning United States Foreign Aid. And they ordered a 90-day pause on all US foreign development assistance programs. By May 9th, 2025, over 176,000 jobs were confirmed lost globally, amidst other disruptions within the global health community. At the time, I was the Vice President for Global Delivery for the Institute for Healthcare Improvement, and I had oversight for projects in Africa and the Middle East. Two of my projects in Ethiopia and Nigeria were quite badly hit. Great work that we're doing all came to an abrupt end. One on maternal and child health, and another project we're doing in Nigeria to improve the quality of health worker training. I'm also a board member of the Ubora Quality Institute. Again, two of our projects in Ghana and in Sierra Leone were disrupted. Literally overnight, close friends lost their jobs. Some were unsure how they were going to feed their family members, and they just became underemployed. By 2030, Ghana is scheduled to exit the Global Alliance of Vaccines Initiative, Gavi, on account of having achieved a middle-income status. Our cost build-up for the purchase of vaccines is going to increase until in 2030, we're going to have to cough up $51 million every year to purchase the vaccines on our expanded program of immunization. Global organizations like the World Health Organization and the Global Fund, which fund HIV, TB, and malaria, all face tough decisions as we speak, with ripple effects that will be felt far and wide in Africa and beyond. Amidst the confusion with this unmistakable disruption, it was the rallying cry of my colleague, sister, and friend, Sipo, that beckoned us to consider a new future, where Africa and Africans stand up for themselves, and where we forge new partnerships with people who are ready to work with us to advance their interests. Sipo said to me that the impact is serious, and it needs many hands on board, hoping it lands on ears willing to listen and act. She was working with me on how we can get funding to plug the gap that had been created to continue the great work that the USAID was pulling away from. We have had COVID-19. We've also had Mpox since 2020. And quite recently, in a meeting with the Director General of Africa CDC and the CEO for Gavi, President Mahama perhaps summarized the threat of pandemics best when he said that the next pandemic is a matter of when and not if. The next pandemic is a matter of when and not if. If that is so, and I have no reason to doubt it, then is Ghana prepared for the next pandemic? Fortunately for us, in February 2025, the International Health Regulation Group, working in partnership with Ghanaian experts and other partners, conducted a joint external evaluation with independent experts from Mauritius, Kenya, Rwanda, and Uganda, also with some inputs from WHO and Africa CDC. They evaluated Ghana's preparedness to prevent, detect, and respond to various health threats. They identified the following strengths and weaknesses in their draft report. In terms of the strengths, they said that Ghana has comprehensive national policies, strategies, and plans in addition to regulatory frameworks. Ghana has also done a great job of ratifying international agreements. We have robust multi-sectoral coordination mechanisms. We have a tiered national laboratory network. The workforce development is prioritized. And a host of strong public-private partnerships, well-established national immunization programs, and emergency vaccination campaigns. These were the strengths of our public health system. Then they talked about the weaknesses of the health system. Inconsistent enforcement of policies and regulations. Of course, as always, we are very good at developing the policies and the strategies, but when it comes to reliable implementation, sometimes we fall short. And then suboptimal multi-sectoral collaboration. So when you talk of an outbreak like cholera, you know that you would need people who are providing water, people who are addressing sanitation. These are outside the purview of the health system, so multi-sectoral collaboration is important. Fragmented budget allocations and a heavy reliance on external donor support. Human resource shortages and workforce retention issues. Laboratory and diagnostic capacity at lower levels. Weak data systems. Limited cross-border collaboration, and the like. In summary, they said, overall, Ghana has built a solid foundation for health security, positioning the country to effectively prevent, detect, and respond to public health threats while contributing to regional and global health security efforts. On the flip side, they said that despite notable progress in health security, Ghana faces challenges that hinder the full implementation of core capacities under the international health regulations. Human resource shortages and workforce retention issues present major barriers to effective health emergency prevention, preparedness, and response. There's a critical deficit of specialized personnel, particularly in radiological, chemical, and veterinary health sectors, with high attrition rates in rural areas, and no national surge workforce plan for rapid deployment during emergencies. Laboratory and diagnostic capacity at lower levels remain limited, with insufficient high containment facilities, biosafety infrastructure, and diagnostic capabilities for priority pathogens. Weak data systems, including inadequate national laboratory information system, and poor data interoperability further compromise disease surveillance and response efforts. In conclusion, I will say that we expedite actions to address these weak areas to improve our limited capacity to prevent, detect, and respond to health threats. Because I'm now acting CEO of the National Vaccine Institute, and because the NVI has sent a very strong contingent here, if I don't speak about the NVI, its mandate, and the progress to date, I'm sure I'm going to get into trouble. The only thing is that in this circumstance, I cannot be making recommendations to the President, to the Health Minister. I have to make the recommendations to myself. So I'll talk about achieving vaccine self-sufficiency in Ghana. As we all know, vaccines have saved millions of lives in the world. Only 1% of the vaccines used in Africa are manufactured in Africa. It is therefore not surprising that the Africa Union, under the Africa CDC, has set a goal that by 2040, Africa should be able to manufacture at least 60% of the vaccines that we use here. In the wake of the COVID nationalism, vaccine nationalism that characterized the COVID-19 response, the government took the bold decision to set up the National Vaccine Institute, tasked with the mandate of coordinating and supervising research, development, and manufacturing of vaccines and sera, like anti-snake sera, I'll come back to it, and related matters in Ghana. I'll just dwell a little bit on a few of the achievements because in May this year, the NVI clocked 2 years. We're just 2 years old, very young agency, still building up, but there are a lot of things that we can speak about. Modest achievements. We have a powerful secretariat, which was on the previous slide, that has been set up in the cantonment area. Ghana's model for manufacturing is a public-private partnership model. So the government now has selected 2 private companies to lead on manufacturing. These are the Atlantic Life Sciences Group and the DEK Vaccines Limited. We have also done some work with the FDA to support them to achieve WHO Maturity Level 3 as a regulatory agency for vaccines manufacturing. The NVI has also facilitated a number of tech transfers with international organizations that are more advanced in vaccine manufacturing to partner with these 2 private manufacturers to be able to advance the cause. And we've also established useful partnerships with the European Union, the German Economic Development and Cooperation Agency, GIZ, their technical implementers, the World Bank, Africa CDC, WHO, universities, home and abroad. More recently, we visited UHAS to learn more about the great work that you're doing in the vaccine space. And tomorrow, I will say a little bit more about how we are going to take our partnership forward. In terms of recent updates, we got some very good news at the National Vaccine Institute just this month. After months of testing, quality and safety checks by the Ghana Food and Drugs Authority, they issued the Atlantic Life Sciences Group market authorization for the manufacture of snake venom anti-serum in commercial quantities. Of course, I have a vial in my office, but that was what was used for the testing. Now, we are going to manufacture it in large quantities, and this is significant because the manufacturing process tested our systems and gave us a lot to learn from as we prepare to go into actual vaccines manufacturing. As far as snake bites are concerned, in sub-Saharan Africa, an estimated 1 million snake bites result in mortality between 10,000 and 30,000. In Ghana alone, every year, we suffer about 9,600 snake bites, at least if you look at the reportage between 2015 and 2019, with a case fatality of 3%. 70% of them are happening in the rural areas. So it is an issue, and it results in lifelong disabilities like amputations, chronic wounds affecting survivors, and all of that. So the plan of the National Vaccine Institute and the Atlantic Life Sciences is to meet our national and hopefully our continental supply of snake venom antiserum by producing what Atlantic Life Sciences describes as a locally produced, affordable, and multi-species targeted snake venom antiserum. I'm told that it can handle bites from about 18 different snake species. So it's a big deal. Also in this month, the National Vaccine Institute convened a meeting of Atlantic Life Sciences, the Noguchi Memorial Institute, to kickstart planning towards developing our first fill and finish vaccine product, which will be the tetanus diphtheria vaccine. That is likely to be the first. And this followed an earlier meeting with the Food and Drugs Authority, where we now started looking at how the potency tests are all going to come together. The assurance is that the NVI wants to be sure that the vaccines that are manufactured are of the highest quality and standards for the people of Ghana. I would want to assure you that the NVI is alive to its mandate and will proactively play its role in supporting President Mahama's vision for effective management of public health emergencies. At the congregation tomorrow, I'll say a little bit more about how we are supporting vaccine research and development in our universities, including UHAS. The disruptions to global health financing, in addition to Ghana's accelerated transition from Gavi program, imposes significant financial commitments on us. This calls for a massive improvement in domestic resource mobilization and a strengthening of old and new partnerships. In the immediate horizon, two government policies give us hope. The policies are uncapping the National Health Insurance Scheme and a recent presidential directive for expedited releases of statutory collections. The point is that in the past, the government, by regulation, did not release all of the funds collected into the National Health Insurance kitty. Some was retained. And it is the policy of President Mahama that 100% of the National Health Insurance levy should be given to the Health Insurance Authority. This will free up enormous additional resources that can be deployed in critical interventions like the purchase of vaccines, free primary health care, and other government priority projects. Next month, President Mahama, who is a Gavi board member, is helping to raise funds at the Gavi replenishment meeting in Brussels, where Gavi has targeted itself to raise $9 billion for their next cycle of implementation, this is between 2026 and 2030. And the expectation, as the conversations are unfolding between President Mahama and the Gavi CEO, is that about 80% of this amount should be made available to Africa and other countries in lower middle-income countries. So I've said a lot. I've said a lot about the quality of care issues. I've spoken about the vaccine self-financing challenges. I've talked about the global financing challenges. But it's not as if old problems went away. All of these new disruptions are superimposed on existing challenges. And the one that I would want to focus on would be the quality of care gaps. And these quality of care gaps are both global and local. So in the work that was done by the National Academy of Sciences, Engineering and Medicine, and then also the Lancet Global Commission, they pointed out that poor quality contributes to more than 50% of deaths in some conditions. So you look at the graphs, the red line on the left, and then on the right, the blue line. you would see the contribution of poor quality to adverse outcomes, to mortality. And what was even more outstanding from the Lancet is that poor quality of care accounts for more deaths than lack of access. So while not being able to see a doctor or go to a hospital is an issue, getting to the place and getting poor quality care is even more of a bigger issue because more people are dying from poor quality care. And if you look at the graphs, if you see diseases like the cardiovascular diseases, trauma and injuries, neonatal deaths, tuberculosis, vaccine-preventable diseases, the issue of poor quality of care is really big. And the work that was done by Lancet revealed that if we are able to develop quality health systems, every year we'll be able to save not less than 8 million people from dying. Then there's the whole matter of the patient experience. At the end of the day, it's about how the patients feel when they come to the hospitals and when they interact with the health professionals, or when the community health workers go into the communities, the experiences that they have. And up to a third of the patients said that the quality of care is very, very bad. They don't have any good experiences when they interact with us. There's disrespectful care. We insult them. Am I the one who asked you to get pregnant? What are you doing here? The consultations are short. Before you finish complaining, there's a prescription on the desk. Poor communication. I had my own experience many years ago when I prescribed diclofenac suppository. And you know where suppository goes. So I asked the patient to come back after a week. Patient comes back. How are you feeling? Feeling okay? How did you manage the medicine? He said, oh, doc, it was difficult, but I swallowed all your bullets. Swallowed all the bullets. So then this started a very interesting conversation between myself, the patient, and the pharmacist. And I was like, no, I advised her. This is not what I said to her. Patient has been swallowing suppositories for 1 week. So when the patients complain about poor communication, I have played my part, I suppose. And then long wait times. It was always very fascinating to me when I was working in Georgia. We would appear at about 8 o'clock, and the patients would appear 5. Sometimes I would be at the clinic until about 3, 4, and get a call to go and operate in the theater. And I would be feeling sorry for the patient. So I would say to them that I've been summoned to theater. It's going to take me quite a while before I come back. So if it's not critical and you can come back tomorrow, let's do that. If it's super urgent, maybe we'll see you at the emergency room. And every single time, the patients will say, we will wait. And you go and come back and they're waiting. I cannot tolerate that in the bank. I can't stay in the bank for hours waiting to be attended to. And for some reason, it seems to be acceptable that people wait for hours and hours and hours on end in the hospitals. And this is why a third of the patients are complaining about their experience of care, that it is not good. So as far as the work, global assessment of the quality of care issues is concerned, there was one very strong observation that every time we talk about universal health coverage, everybody should be able to have access to care. But after seeing the impact of poor quality of care, they concluded that universal health coverage without addressing the quality of care is meaningless. If you are going to put a facility in a village, don't just say that you put a facility in a village, they have a few medicines, they don't have the requisite qualified staff, they cannot treat the conditions that are afflicting the people. The recommendation is that if you are going to address access, make sure you are equally paying attention to quality of care. So now perhaps I'll shift some attention to Ghana. And this slide should make you a little bit happy, because if you look at the trends over about 30 years, the results indicate that Ghana is moving in the right direction as far as outcomes are concerned. Maternal mortality, infant mortality, under 5 mortality, immunization rates, facility-based deaths, all of them are moving in the right direction. Life expectancy is moving in the right direction, which means that something is working well. But of course, as I say, sometimes you have to disaggregate the data and look at the regional disparities and know which of the regions that are doing very well, those that are lagging behind. But the challenges also are there. We are not saying that they don't exist. They have the triple burden of disease, non-communicable diseases, communicable diseases, injuries staring us in the face. Non-communicable diseases have a prevalence of about 42%. The communicable diseases, about 48%. We are still grappling with hypertension prevalence of about 25%, and diabetes. These are all very much deserving of our attention. Many people may not recognize it, but Ghana has had a national healthcare quality strategy which we implemented between 2017 and 2023. The aim was to apply various improvement methodologies and a patient-centered approach to improve health care. Recently, an independent evaluation was conducted by Professor Fifi Yosin of the College of Health Sciences on behalf of the Ministry of Health. And it revealed the following strengths. One, that there was measurable improvement. Maternal and child health outcomes actually got better. Two, that we had functional governance structures. So at the Ministry of Health now, when this strategy was rolled out, we established a quality management unit, the first time within the Ministry of Health. The Ghana Health Service also developed the Ghana Quality Strategy Implementation Guidelines. And for now, they're setting up quality management teams right from the communities through the district to the higher levels. We have structured patient feedback systems. You know about the community scorecard, where focus group discussions are held within the communities. They give feedback about their impressions on the quality of care. Staff satisfaction surveys are being administered so that staff members can also have their views being brought on board. There are some facilities in the country that are quite ambitious, and they are going beyond basic minimum standards to seek international accreditation. So with the likes of COSASA in South Africa, then the Joint Commission in the US, and so on and so forth. We also had challenges in terms of, these were the things that worked well. Then, in terms of the challenges, in terms of what could be better, well, the evaluation found out that there was suboptimal oversight by the quality management unit. You know that in Ghana we have this design where the Ministry of Health is into policy, regulation, oversight, and then they have over 30 agencies that are actually into implementation. So when you are set up within the ministry, your role is not to implement, but you're supposed to support the agencies to implement. And sometimes that oversight can be a bit challenging. And then they also talked about the fact that there was an undue focus on service delivery. The agencies within the Ministry of Health are not just about service delivery. We have the teaching hospitals, we have the Ghana Health Service, we have CHAC, Ahmadiyya, all of those people deliver service. But then you also have health training institutions. You have regulators like the Food and Drugs Authority. And the criticism was that we focus too extensively on service delivery without looking at how we can systematize quality within training institutions. And then they also talked about the fact that training of facility managers is lacking in basic managerial skills. And later on, I'll connect this point to some other observations about efficiency. And then finally, there was ineffective adherence to clinical protocols for priority conditions. So if you look at the strategy, it says meningitis, malaria, non-communicable diseases, maternal and child health. All of these have evidence-based protocols for treating them. And when you don't adhere to the correct evidence base, it means you are deviating from quality. Remember the definition. It says evidence-based professional knowledge. And they found that that was not always the case. So, this brings me to the last lap of my presentation, where I intend to highlight a few interventions. And as a guiding framework, I leaned on 7 cross-cutting recommendations that came from the global quality reports. But of course, I tailored them to the Ghanaian context. Right now, if you look at the organogram, the quality management unit sits within the policy planning, monitoring, and evaluation unit, which is fine, I mean, for now. But given the level at which we want to place quality and the emphasis that we want to place on systematizing it, some of us have the opinion that at the very minimum, the quality outfit should become a full directorate within the Ministry of Health, staffed by very competent staff who have the capacity to be able to oversee the broader agenda that we have. Then there's my brother here, Dr. Winfred Barr, who is doing a lot of work with the Health Facilities Regulatory Agency. Now, this agency is our foremost agency under the Ministry of Health that has the task of licensing and monitoring all public and private health facilities for the provision of healthcare services in Ghana. The last time I checked, Ghana had an estimated over 33,000 health facilities at various levels nationwide. It's also possible that this number is underreported because even according to HIFRA, one of their major challenges is the lack of national data on the total health facilities across the country. Now compare this huge number of facilities with the staff strength of HIFRA. They are about 152. And once HIFRA gives you, a certificate to operate, per their regulations, they are supposed to come around every year to monitor and inspect. So, how are the 152 people going to track thousands of facilities every year? I think that they have to live in the field and always be out there monitoring facilities. So it was my thinking that HIFRA would have to change in terms of their thinking on how they are going to execute this mandate. And what I'm proposing to HIFRA is to consider accrediting a massive pool of quality inspectors across the country drawn from among our health professionals. First and foremost, it will be important to train the quality managers and the safety officers in the hospitals so that every hospital has a full team of well-trained officers who are overseeing this. And in addition, for purposes of the inspection and the oversight, HIFRA then accredits all health professionals across the country as HIFRA accredited inspectors so that they are positioned everywhere and can go around to support the 152 people, because for us to even contemplate that HIFRA is going to employ tens of thousands of people for the sole purpose of inspection, it's not feasible. So this is where we have to look at both ways of building capacity and undertaking the mandate that we have. They do not need to be full-time staff of HIFRA, but will be useful in rapidly ascertaining HIFRA's mandate nationally. Of course, HIFRA can also consider digital technology, and it is good that they are already moving in that space, where they are going to use technology to help them in their assessments, rapid analysis, and so on and so forth. I talked about the fact that HIFRA's mandate is really helping all the facilities, public and private, to achieve basic minimum standards. This is good because you don't want to go to a health facility only to realize that they don't even have sphigs to take your blood pressure. They should meet basic minimum standards. But as I said, there are some very ambitious facilities in the country at the moment that are seeking international accreditation. And this is where I think that beyond meeting basic minimum standards, HIFRA should consider rolling out a nationally led accreditation program that is accredited by ISQA, the International Society for Quality in Healthcare, under the distinguished leadership of Dr. Barr. But of course, other countries have done it. My own friend, Dr. Amina Malik, has set up a nationally led accreditation system in the Kingdom of Bahrain in the Middle East. So it's really possible to learn from each other and to set up a similar thing in Ghana. The NHIA, still under leadership and governance, has done a phenomenal job of using its credentialing process and clinical audits to improve the quality of care. So what happens is that if you want to be a facility that delivers care under health insurance, you are credentialed by the National Health Insurance Authority. And then they would occasionally come around to check or to compare the treatment that you offered to the various conditions so that they see whether you are using the right evidence as proposed by the Ghana Health Service to treat the condition. So these are all good. But other countries are also trying other mechanisms that I think we should consider. And that is that they are using the payment mechanisms to incentivize for quality. Because you're welcome, Honorable. Because Honorable has succeeded in disorienting me. Because as a payer, you have power. When you offer the services and I don't pay you, you will not get the resources you need to be able to run your facility. So what the other countries are doing is to use the payment mechanism to incentivize the healthcare professionals to deliver quality of care. And what is done is that now they begin to use look at metrics or indicators like readmission rate. Is it the case that when you treat people, in 3 days they are back, that you didn't actually treat them well, so the sickness didn't go away? Post-surgical infection rate. How come 90% of all your surgical cases are coming back with wound infection? It means that your theater and your service delivery is not optimal. And we are also looking at length of stay. Why is it that in my hospital, when I finish a cesarean session, the woman can go home after 5 days, and in your situation, it's taking them 3 weeks on admission. They've developed wound infection, all kinds of things, and we have to treat them, so average length of stay. And what these health systems are doing is that when you are able to achieve these quality goals, you are paid a little bit higher than the others. So a mix of interventions, push and pull, carrot and stick, and then we get the system moving. I also wanted to reflect a bit on the recommendation that came for redesigning the service delivery. And in this instance, I will focus on the non-communicable diseases where we have prevalence rates of about 42%, which is pretty high. Recently, the government rolled out the Ghana Medical Trust Fund to support the management of complications of non-communicable diseases and training of subspecialists, which I think is a good intervention, because then it is seeking to focus on areas that are not typically being addressed by the National Health Insurance. Indeed, if we are to put all of the burden on the National Health Insurance scheme, we would compromise its lifespan. So it's a step in the right direction to look for money to train more people and then to deal with the complications like dialysis and maybe transplants and co that are not currently being handled. But I would say that the fight for sustainable financing of non-communicable diseases, which is what the trust fund is supposed to address, will not be optimal unless it is linked up with an effective free primary health program, a redesigned school feeding program, and a more robust exercise regimen in our schools and communities. It is good to know that the government's free primary health program is considering redesigning the basic minimum package to include screening for breast, cervical cancer, colon cancer at the community level. The move is to integrate the non-communicable diseases into primary health care at the lowest level, because you want to catch it early. You don't want to wait for them to get into complications before you say that the Ghana Medical Trust Fund is going to sort them out. Similarly, we want to look, and before I get there, I would say that there are good examples in the Catholic Hospital in Bato in terms of how the primary healthcare system is being used to screen for cervical cancer. That I think we can learn from. The school feeding program would also benefit from a more intentional collaboration with the Ghana Academy of Nutrition and Dietetics to guide on food choices. We have to now begin to think of the younger generation and begin to influence their food choices right from the onset. And the school feeding program is a good example of what we can do in terms of feeding them good quality food. And this is when I think that it is good for qualified nutritionists. And I know UHAS is at the forefront of training these nutritionists to be integrated into the school feeding program to ensure that the children are being fed right. And finally, Because of constant changes in school calendars, I know that in some places there's virtually no sporting activities. A lot of our communities have been taken over by concrete jungles, no playgrounds, and all of those things. We have to redesign our neighborhoods, redesign our schools, redesign our curriculum to make sure that there's ample opportunity for the children and for all of us to be able to engage in sporting activities. What I'm calling for, essentially, ladies and gentlemen, is an integrated approach to non-communicable disease management from the primary level to the tertiary level. I'll then jump a little bit into data. When I used to work for the Institute for Healthcare Improvement based in Boston, the founder of IHI, my mentor, Dr. Don Berwick, used to say this, something that always fascinated us. He said, "Some is not a number. Hope is not a plan, and soon is not a time." Some is not a number, soon is not a time, and hope is not a plan. And I'm sure you've heard in your management lessons that if you're not counting it, you're probably not doing it. So those of us who work in improvement science know that measurement is key to be able to close the various gaps, for us to know specifically what is being done. And in Ghana, it is very challenging to find one place where you can measure true performance across the health system. We simply don't have it. Where, with a click of a button, I can say that in terms of the numbers, this is what is coming from the teaching hospitals, all the teaching hospitals. This is what is coming from the Ghana Health Service. This is what is coming from all private hospitals. So it's always very difficult, unless you undertake this national service, to have a good sense of performance across the health system. Private facilities are delivering care, and sometimes you don't have any sense of the numbers that they are attending to. And it's a black hole that we really have to address. And fortunately, I know the ministry has developed their National Health Information Systems Strategic Plan. Big, long name, time to implement it. And to do that, we would need the Ministry of Health to streamline the reporting standards so that every agency, every one of these private facilities, the teaching hospitals all have clarity on what they are supposed to report on every month or whatever the reporting period is. The private health sector would need to come on board and to report on quality metrics similarly, so we know exactly what is going on. And as we collect these large data sets, we can also deploy artificial intelligence that would help us in rapid analysis of the trends so that we can then respond to when things are not going well, and then also learn when things are going very well. Reverend Professor Aite, as I transition into transformation of the health workforce, always talks passionately about strengthening preclinical, basic, and paraclinical sciences. Incidentally, I'm told that this is an area Professor Mills used to advocate for when he was vice president. To quote Prof. Aite, our healthcare system will become sustainable if we invest heavily to raise the next generation of preclinical scientists, people who are teaching the anatomies, the physiologies, and embryology, and so on and so forth. The quality of healthcare will be severely compromised if we neglect the preclinical area. I'm told that the faculty numbers in this area are few, and this is a direct challenge to UHAS, because UHAS is fit and strong to address this national problem. We also have the opportunity to redesign pre-service training curriculum in addition to the in-service training programs. Currently, what happens is that in some of my own improvement projects, we have to systematically train people who did not have that training when they were in medical school, in pharmacy school, nursing and midwifery school, So this is what we mean by pre-service. Before you get into service, it should be made part of your curriculum so that when you come out, you already know about improvement science. And what are the components of improvement science? Systems thinking, the theory of knowledge, the psychology of human behavior, and then learning from data and variation. These things should be taught in the schools before you even graduate. We should also teach people about management skills and management practices so that you don't just miraculously find yourself as the head of an institution overnight. You heard about my program at GIMPA, and then also the fact that I did the program for leadership development at Harvard, which is the equivalent of the executive masters. But when my wife and I got to Joje, right after the house job, we were very amused to be appointed onto the management team. They said we were co-opted members of management. I was like, oh, Lord. And when I went for the meetings, the financial information was overwhelming. You know, financial statement, profit, margin, this, that. I was like, Adoko, we're in trouble. And we had to take decisions. So let's just anticipate that as a healthcare professional, one way or the other, you are a leader. You will be given an opportunity to serve in a management position. And let's build it into the pre-service curriculum to build their capacity to take up these leadership roles when they come. The next recommendation has to do with igniting demand for quality. Ignite, I think it's like set fire or something like that. So spark. Okay. So he says a spark, I accept. So we want to stimulate, we want to spark, we want to create excitement about involving patients in the care. And this is very important because it means that we have to be very intentional in engaging, in empowering, and in amplifying the voice of the customer, in this case, the patient. In my over 16 years of work in the improvement space, I've come to accept that not all health professionals are comfortable with empowering patients and involving them in the care. Some don't want to be challenged, some think they know better than the patients, and all of that, and they are just not comfortable. But I would argue strongly that this is the way to go. Some time ago, many years ago, I had interactions with colleagues at the Cincinnati Children's Hospital in the United States. And they had this very fascinating program where they would involve the mothers of the children in the care decision. If there was a medical error, they would explain to the patients. And you know about medical legal suits in the US, how patients sue for negligence, for error, and all of that. And I asked, so what did you learn from this experience? And what they said was that they had actually observed a decline, a reduction in the lawsuits against them. The patients trusted them more because they felt like the healthcare workers were being very honest and upfront with them, so they would not sue them. And they trusted that the healthcare professionals were actually doing their best. Health outcomes also improved. We did a project in Ghana where in one set of health facilities, we decided that the quality teams should involve patients. And in another cluster, it was just purely health workers. When this project was independently evaluated, the outcome was that the cohort with patients got better outcomes and quicker too than the one with only health professionals. I sat in some of the sessions and I was very amused that the patients had views on the design of the referral form. I would have thought that this doesn't concern the patients, but they have strong views on how referrals should be done. This is why the likes of Professor Benka strongly believe that till we strengthen the community level and our engagement with our communities, we really are not going anywhere. Involving patients is the way to go. They will be empowered. They will contribute to their treatment. They will comply with whatever treatment it is that you prescribe for them because they are part of the decision-making process. So I will support the efforts within the Ghana Health Service to scale up the community scorecard, which is something that they are trying out in a number of communities. I know some hospitals that are also talking about patient protection councils. So these are councils that they run ideas by if they want to implement things. And then there are also thoughts in certain quarters to include patients on your quality management teams in your hospitals so that they discuss the various things with you. To be clear, I will also advocate, and I know this is a little bit controversial, I will also advocate for public sharing of data that shows the performance of the hospital. So it is there, it's available, people can go and check it out. And I know my brother, Dr. Maxwell Entry, even talks about the fact that we can use the data to rank facilities. The way you go and check out hotels and say what are people saying about the quality of, not quality of care, but how nice the hotel is and the services, we should be able to check out the hospitals in that same way. And so if we create this quality management directorate, then we can focus on some of these outcomes, on people's confidence in the system, the system's competence, the patient experience, financial protection. All of this should be publicly available so that patients can be really engaged if we are honest about sparking the interest of the patients in what we do. Now, I'll get into also a little bit of a difficult area about addressing issues of integrity and accountability. Fortunately, I haven't added probity to it. So we'll see how it goes. Recently, and I'm sure you remember the interaction that the health minister had with colleagues at the Atta-Mills Teaching Hospital, the issue of the absence of equipment and the breakdown in equipment came up. Critical equipment needed for providing quality care are either not available, they are broken down, they are obsolete, or they are non-functional, whatever. The patients, in their words, are not feeling the quality of care, so to speak. And the clinicians, the doctors, the nurses, the pharmacists who are treating the patients also feel frustrated because they don't have the equipment to deliver the best of care. So my brother Kemeche and I decided to take a quick look at the 2024 Annual Consolidated Financial Statement for the Ministry of Health. You can read it when you have time. For a sector that is struggling to purchase equipment, the following findings were quite revealing. Only 70.7% of funds budgeted for capital expenditure was utilized, system-wide. And then IGF cash and bank balances stood at 1.5 billion Ghana cedis. Meaning that you had enough, actually you had enough, the health system had enough resources to support additional capital investment. The second observation was that only 62% of donor-funded CAPEX, capital expenditure, was utilized, reflecting delays or absorption constraints. So you have $100. You were only able to use $62, and the rest, 38, was just either returned or just left floundering. But you don't have a CT scan. You don't have a labor ward. This is the matter. There was also a finding about significant year-end surplus of 2.5 billion Ghana cedis, not strategically reinvested. So they talked about multiple underperforming service lines, dialysis, physiotherapy, dental care, with many categories showing zero or near zero revenue, despite high volumes of patients. You're seeing a lot of the patients, but we are not seeing any revenue. So this is in line with revenue leakages and weak service monetization. I don't know why the finance people like talking about things and using these kind of expressions. What is revenue leakages? What is revenue leakages? If we are seeing many patients, but we're not seeing the money, why don't you describe what is going on and say revenue leakages? All right. Number 5, they talked about project delays and underperforming infrastructure. Many projects showed less than 60% completion rate. Sometimes it's easy to say we didn't have the money, but when you have the money, you have the people to do the work, but for whatever reason, we are still not being able to execute, then there are fundamental issues that we have to look at. They also talked about rising wage bills outpacing marginal growth in staff numbers. In 2024, the health system witnessed 15.4% increase in the wage bill. The salary component went up 15.4%. But in terms of the headcount, the additional human beings, that went up by less than 0.2%. So you added just about 0.2%, but in terms of the emoluments, that went up 15.4%. Again, something for us to look into if we want to be efficient, if we want to look into adequate use of resources. These are questions that we have to look at. I also took a quick look, because it is not all bad, it's a counterbalance. I also took a quick look at the 2024 audited financial statement of the Holy Family Hospital in Techiman. and had a discussion with the Chief Executive Officer. At this juncture, I want to express my gratitude to Dr. Peter Yabua, who facilitated this discussion. There are fascinating practical examples of effective governance, top-notch internal controls, project financing and execution, effective revenue mobilization, etc., with the overall effect that the hospital has consistently recorded a positive financial balance since 2011. This is Holy Family Hospital in Techiman. So as an improver, the question I have is, how can these, the expression we use is, how can you move from islands of excellence? There's a whole health system. We don't want islands of excellence. We don't want just Techiman Hospital. We want whole system transformation. So how can we learn from the likes of Techiman and systematize the changes that they are making to achieve impact? I agree, therefore, with the health minister that we need to have a very serious conversation about how the sector as a whole, its agencies and health facilities are being managed, and how the money is working or not working, and how we can get managers to turn the agencies and facilities into profit-making entities. Then I'll go on into research, because there's a lot by way of questions that we have, and how we can, learn from research. So whether it's in measurement and quality, digital healthcare, payment and improvement, quality improvement research, there's no shortage of opportunity to learn about ourselves. As an editor of the International Science Journal, it's very disheartening sometimes when you read that, well, not much has been done in Africa. A lot has been done. Perhaps we're just not publishing enough. So again, this is important if we want to develop the quality health systems. When UHAS developed the poster, they described me as an activist, social justice activist. So I thought that if Vice Chancellor is going to go around describing me as an activist, I might as well throw in something to spice things up. And I decided to land on Burkina Faso as an example of resilience. Burkina Faso is at the heart of some Islamic insurgency. You know about the diplomatic attacks from the United States. You know about other threats that they have to national security with repeated coup d'etats and so on and so forth. But they are doing, let me put on my clothes properly so that I can talk about Traore. So, according to the WHO official reports, Burkina Faso has increased the share of the national budget that is allocated to the health ministry from 11.8% in 2013 to 13.7% in 2022. And the WHO has this to say, that Burkina Faso has made significant progress in financing vaccination. I need to explain this. Gavi funds over 50% of the procurement of the vaccines that a lot of our countries use. And the countries have to pay what is called counterpart funding, your share of the cost of the vaccines. And every year, it's a struggle for many countries. So I was fascinated to learn that Burkina Faso has paid 1 year in advance. They always pay 1 year in advance. And you would sit here and think Burkina Faso is some dry, poor land. No, they are showing leadership. They are also increasingly allocating more within the health sector. And they talked about success in coordinating the activities between key stakeholders, the EPI program, the Administrative and Financial Directorate, the Treasury, the Minister of Economy and Finance, and UNICEF, with strong leadership from the EPI Director and a determined commitment from the Minister of Health. This integrated approach has enabled Burkina Faso to become an example to follow in terms of respecting co-financing commitments and sustainability of immunization financing. Ladies and gentlemen, it is not for nothing that the persona of Captain Ibrahim Traore is soaring in Africa. It is not that people prefer military rulers. It is rather the case that the people of Africa are simply tired of non-functional electoral democracies that fail to deliver on the promise of development. We are tired of going to the polls and voting for people whilst our roads remain untouched and our hospitals remain unimproved. The UHAS road from Sokode is a good example. I don't have to go very far. The continent is crying for strong but humble leaders with integrity who prioritize the national interest above all else. Such a leader is who we have in President John Evans Atta-Mills when he set up UHAS as the foremost university for the training of health professionals in Ghana. Today, there is no doubt that UHAS has achieved this purpose, and as President Mahama said a couple of years ago, the dream of Professor Atta-Mills has been actualized. In the early days, we used to be mocked a lot in the newspapers, and this is a cartoon from the Chronicle newspaper that Professor Benka keeps in his pocket. You just check in with him after this program, and you will discover that this cartoon is in his pocket. And they would say the whole university, it is not working. There were cartoons that showed that the university was populated by snakes and crocodiles and lizards, and that there's nothing going on in that Volta bush. So today, it's a source of pride to me to know that UHAS continues to graduate top-notch students. Also, UHAS has some of the best faculty, not just in the country, but in the world. When I came here with the European Union some months ago, and we listened to the work that you're doing, even just in the vaccine space, people were like, wow. UHAS is attracting people from all over the country. You would have thought, when Professor Benka started, that we would never get anybody to relocate from Kolebu to UHAS. Today, we have cardiothoracic surgeons and many others who are very eager to come. If there's any talent that I've learned from the UHAS leadership, it's their ability to attract top-notch talent. And the university is great over the past 13 or so years, not because of anything dramatic, but just because of the quality of the faculty that they have. And they brought their own resources and their own networks here. And so we want to salute the vision that helped in setting up UHAS. I hope that you've had a good time listening to this story. We've learned about various global challenges. We've learned about how they could potentially adversely impact quality health systems. We have learned a little bit more about the Ghanaian context, and we've ended with a number of recommendations that we can reflect on if our desire is to transform the quality of care. Thank you very much.
Kindly take your seat whilst we do another thunderous round of applause for our guest speaker, Dr. Soji Tete. I think we need some melodies of praise. I call on our choir, the UHAS choir, to give us an interlude. very much, University Choir. Whilst the lecture was going on, our whole Central MP joined us. Honorable Potosu, you are welcome. Again, I want to acknowledge Tobio Mamao, who also joined us whilst the lecture was going on. And Anum, you're welcome. I can tell from your faces the questions you have for Dr. Soji Sojitete, because I saw a lot of people jotting down. I saw some doing it in their minds, whilst others were actually penning it down. And so I call on Nana Bafo to lead this session whilst we do the question and answer time. Nana, come on board. Give one microphone to
you. Please kindly raise your hand up and then I'll call you. They'll bring the mic to you and then you ask the question.
Dr. Lecturer, I have a simple question to ask you. First, coming here, I was cautioned. First, I heard about the lecturer being Dr. Soji Sojitete, and I've read a few of your write-ups. So I was quite prepared to come and ask you an intelligent question. But then, I was questioned that your doctorate certificate has already been signed. Whether the question is difficult or not, you have it, so I should forget about my difficult question. I have two questions. One, and you've mentioned Professor Fred Bink over and over again. He might want to chip in. Not that you can't answer. I'm just curious why your topic is premised on global disruptions, as if we don't have enough internal disruptions here to throw our health systems off guard. I've always wondered what's happened to Ghana. There was a period of health sector reform that worked so well. We were making progress, and suddenly everything vanished. And now we tend to explain all our problems on what is happening either in Wuhan or in Trump land or whatever. I wonder why you didn't just talk about disruptions but global. You don't think we have enough internal disruptions? And the issue about preclinical training, I mean, addressing issues of quality from training, not after the people have come out bad. I mean, just want to remind you that beyond the beauty of this auditorium, I know you are too familiar, take a look around UHAS again. It's not yet formed. UHAS is still almost a failure to thrive baby. So as you go back to Accra, I mean, let your advocacy be strong for more resources to come to UHAS. I think in the interim, they might even do with a small catalytic funding to make bigger things happen in the future. So if you're running an experiment, the catalyst makes the reaction goes faster. I mean, so the VC can tell you about that over coffee. And this question, though Fred was not part of the lecture, but it beats my mind. This is the only occasion I can rope him in. Why did we one day wake up in Ghana and think that chips was an answer to maternal mortality in Ghana, or chips was going to reduce maternal mortality, when the best chips compounds you might find do not even have a chair for the nurse to sit on? How was just chips, implementation of chips, going to address reduction of maternal mortality? Fred knows all about chips, that's why I'm kind of breaking protocol to rope him in, whether that was the original intention of chips. It will address some aspect of maternal challenges with pregnancy and this challenge, but that maternal mortality will go away with chips. I'm still confused. Thank you.
Yeah. Okay, so the topic was achieving quality health systems in Ghana amidst global disruptions. The fact of the matter is that Ghana is not an island. We are connected to the global community, and we are impacted positively or negatively by happenings in the global world. When there are things about artificial intelligence, when there are things about climate change, they do impact what goes on in Ghana. And we are in a situation where between 50 to 80% of your procurement for immunization vaccines are supported from outside by the Gavi initiative. So if you have a funding mechanism that adversely impacts Gavi, you should know straight off that it's going to impact your situation. And in a situation where you also know that you are going to exit that Gavi program in 3 years and you have to cover $51 million, you have no option but to take account of some of these global challenges. I also talked about the fact that there are pandemics. Again, you are not an island. By definition, the fact that it's a pandemic means that you are affected. And we all saw what happened in Ghana because of a pandemic and our total lack of preparedness, and how countries in the West literally held Africa to ransom by refusing to prioritize our public health needs, in service of their own. So it is not drawing attention to the global developments for the sake of it, but to let us know how we can work towards self-reliance, which is why I'm citing the examples around domestic resource mobilization, around the establishment of the National Vaccine Institute, and all of the other interventions. So there definitely is a link. It is not to say that we do not have any disruptions. In fact, that is why midway in the lecture, I pointed out that these global disruptions are being superimposed on existing challenges. Chronic disruptions is what you might want to call it. So I hope that is clear. The matter of the preclinical training and the gaps at UHAS. Well, yes, UHAS is very dear to our hearts, and everybody continues to advocate one way or the other for what needs to happen. A lot has happened well, and sometimes we are all, not sometimes, most of the time, or all of the time, we are inspired by what Professor Mills did. You would recall that in the beginning, there was this loan facility that was being, a grant actually, that was being given to Ghana. And President Mills decided that all of the money, I think $20 million or so, should be given to UHAS to set us up. So that was really the seed fund that came here. So we recognize that a lot of people have been connected to the vision and have made an enormous amount of contribution to make us come this far. Again, I remember that in the early days, we were struggling to put up the Hohoi campus. And there was a gentleman, I forget his name, he was with the Ghana Commercial Bank in Accra. He then advocated for us to get 1 million Ghana cedis to build up some facility in Hohoi. So I'm just recalling the fact that many people have contributed. Personally, a few weeks ago, I came to UHAS with a team from the European Union, GIZ, and co. to look at how we could partner. And it's just become very clear that in the area of vaccines research, there's a lot that is underway. So we are thinking through what we can do, if it is possible to support UHAS to complete that multipurpose lab facility that has been sitting there for quite a bit, and then also potentially to consider supporting you to become some vaccine research innovation hub. So the conversations are still underway within the National Vaccine Institute and the partners. And I know that, inshallah, something good will come out of it. Thank you. Fortunately, you gave the last question to Prof. Benka. If the drum is there, you don't beat the side. So it's all well and good. Prof. Benka, over to you.
Yeah, so thank you very much. I think it's a very simple answer. The CHIPS system was to take healthcare to the doorsteps of people. That alone changes the decision-making process. Most of our women are dying from bleeding. If they get to the facilities early, lots of them will be saved. So the idea was that get it near, make sure the decisions can be made quickly, and let's cut out the delays that take the women to the health facilities. We can discuss more about this in the break.
Thank you. My name is Dr. Felix Nyandi. I'm the head of Department of Nursing, UHAS. Dr. Soji Sejitete, thank you very much for an enlightening lecture. In your definition of quality by the Lancet Global Health, you said it should be a system that the people trust. I'm looking at, my question is from the point of view of quality from the perspective of the service user. A lot of Ghanaian patients don't have good experience when it comes to hospital care. If we want to improve quality in the Ghanaian system, you said about 42% of non-communicable disease burden. To me, early screening and detection of hypertension and diabetes alone can help us to reduce even the number of chronic kidney diseases we have. Unfortunately, for a lot of people, they come to the hospital as their last resort because of their experiences. And the reasons are not too far-fetched. The biomedical nature of our healthcare system, the overburdened healthcare workers. A lot of healthcare workers are leaving. Then we try to bridge the gap with student nurses, rotation nurses, house officers. So patients come and they don't get the best of quality that they think they should get. And so until it becomes a sickness that they cannot handle, they won't come to the hospital. And so how, in terms of this improving quality of care, what are the things that we need to do to ensure that patient-centered care, family-centered care becomes part and parcel of our healthcare system? Thank you.
So I would think that this is even more of a contribution, what you are adding to it. I used to work with the head of the patient safety outfit at WHO Global, Dr. Neelam, and she said that of all of the dimensions of quality, of all of the areas in which one could improve the quality of care, the one that she thinks we should focus on is empowering the patient, involving the patient in care. Because if the patient is empowered to demand for better quality services, it changes the power dynamic and it refocuses the efforts. So yes, to the fact that early screening would help, which is why I was making the point that the Ghana Medical Trust Fund is good, but if we are waiting for people to develop complications before we find the money to treat them, it's really not ideal. One way is by the communication. So as we integrate these early screening programs into the primary health care, the way in which we interact with patients with respect would really make a difference, because then it would engender that spirit of trust that, you respect their views in terms of what they do. We should also find ways in which we can include them in care. I mean, I recall that as a district medical practitioner, we had something akin to a board, and that board had village chiefs, queen mothers, and so on and so forth. So they felt like they had access, and if they had issues, they could raise them. So making this systematized across and saying that let's get the communities involved. In some conversations with Prof. Binka, as we prepared for this, we talked about the fact that perhaps we should even change the way in which we analyze the data. Instead of saying antenatal attendance, skill delivery, and all of those things, why don't we disaggregate the data according to communities? And when the time comes to share on performance, let's have community debates and discuss community performance with them. And you would see how other places we have 100% of the women in your village delivering in hospitals, and in another village, only 2 of them are going to deliver, and then we can have a discussion about it. So it's really all about bringing the care closer. Of course, for the tertiary centers, well, you could have your focus group discussions, but there you are having these formalized structures. You are forming the quality teams, you are forming governing boards, you are forming Ghana Health Service Council. The advocacy should get to the point where we are putting patients on all of these platforms, and not just 1 or 2 patients as a token, but we are having enough that can influence what is ongoing. But so we change the mindset to the point where we know that patients are part of the care, and we want to co-design with them. It's really going to be difficult, because then you're just giving us the perspective of the health professionals. The expression is, nothing about me without me. That's what they say. Nothing about me without me. So you want the patients to be actively involved. So this is really where we need to get to, and let us work through the messiness together. Now, thanks for your contribution.
My name is Terry Nosting. I'm from the Whole Teaching Hospital. I appreciate the talk you gave very much. I wanted to add a few comments to it, and then hope that you could advance those discussions forward. I think a lot of the problems are often systemic, as you've rightly pointed out. I've experienced that we would often have legislative instruments that would try to fix one problem. And so we identify a huge need. We tried putting legislation to go monitor that, to try implement a program, to try fix it. But then we don't often look at it on a very systemic level. So you would find out that we would have regulatory agencies who would have functions mirroring one another. Oftentimes it creates conflict. And when there's the instance where we really need all our arsenals on board, they will end up fighting each other rather than helping advance the cause. A classical case for me would be the instance of INCAS diagnostics. When COVID was hitting hard, INCAS had come up with a diagnostic test, but FDA wouldn't accept anything below 75. But it was better than nothing. They were insisting on having a certain preset standard. So how do we ensure that systems that are brought up by local people would also get to be brought to the fore? You mentioned the case of Bato. I was privileged to have worked with the CCPTC for about 5 years, and I was part of Dr. Efe's team. I know they are doing phenomenal. Why are they not having such training programs integrated in the training of all health cadres? We seem to be more focused on having to get a certain caliber of people do only the training. We seem to be more intense about just ask and do it. I think we need to think about the more decentralized approach, improve systems, and ensure that whilst we want to ensure quality by world standards, we also do not stifle the growth of local ideas that can fix local problems in a unique way. Lastly, I also wanted to add that some of this fixing of the problem is happening in health institutions, but it's also dysregulated. So I know as a laboratory scientist that there are 5 or 6 facilities that have attained ISO 15189 accreditation. And when I sit and I see my facility going through that, I wonder, will the patient only get world-class standard when they come to the lab, what happens at the OPD. Of course, they may not have an ISO, but then for all areas that require, there has to be a holistic idea that this is what we want to go. All agencies need to have a harmonized structure. Then we can make sure that we do not do patch and fix, but resolve the system in a whole. Thank you very much for your comment.
I think that was strong to reaffirm a lot of the things that we discussed. Thank you for your comments. So generally in improvement science, what we say that for changes to happen across the health system, you need three things. You need the will at the leadership level, then you have to generate ideas, and then the third one is execution. In terms of the ideas, there are two sources. One is the published literature. People have done research, there's the evidence base, and so on and so forth. The second one is the local knowledge, which you talk about. So we, in the improvement field, we don't think the leaders necessarily have all the solutions, which is why when we want to solve a problem, we bring the people who are closest to the action, the frontline workers there, but the leaders are involved for purposes of putting in policies that systematizes some of these things. So yes, the more we can learn quickly from what is working at different places and make it the normal way of working, the faster we will be able to see improvement. So I've taken notes. We'll see how it goes. Yes.
Yeah, thank you very much. May the soul of our great leader, Professor Mills, rest in peace. Prior to the establishment of UHAS, we heard that there will be a program called sports medicine, and that the school will be attached to a stadium complex. I want to know if they are still doing such a program, and if they are doing it without the stadium complex, because then we were very happy as a young people that we also, if we are not going to benefit from the school program, at least we'll benefit from the sports aspect. So I want to know if they are still doing such a program without the sports complex. Thank you.
I'm smiling before I answer your question. So we graduated the first cohort of the sports scientists this year. No, last congregation, that was November last year. The program is ongoing. We don't have the sports complex yet. Discussions are ongoing to use the Adaklu sports facility. So far, approval has not been granted yet. The school dean and the management of the school went to the Botiano place to have a look, but the previous government, it wasn't possible to have any approval to use the place. So yes, we are having the program. We want to thank Mr. Chance of Chance's Hotel, who gave us his gym to get the initial accreditation. Right now, we have the sports, the lab complex. We have a huge room dedicated for the program, but we are yet to have the necessary equipment to train them as is. The difference for our program is that we are training like a sports doctor. We are not training an athlete, so that is the difference. We are training people who can assess and care and manage sportsmen and women, okay? So we are not training somebody to be physical. The person can, yes, be physical. You preach what you do what you preach, am I right? But the focus of the program is to train sports and science medicine practitioners, not athletes. So some of the parents will ask us, is the person a PE teacher? No. The person can do, but the focus is on sports and exercise medicine, not just physical activity. Thank you.
All right. Thank you, Dr. Soji Tete. My name is Obed Kweku Amenyo, a proud alumnus of this university, School of Nursing and Midwifery. Doc, you've checked all the boxes. We've done justice to the topic. On the issue of challenges, you mentioned that patients' experience in the health facilities are always unsatisfactory. You mentioned long or delayed time in the consultation rooms and all that. The cause undeniably can be attributed to low patient to healthcare worker ratio. UHAS has been the university training all cadres of healthcare workers. The challenge, however, is that after training, we don't get the work to do. In the facilities, it's not as if the healthcare workers are not available to do the work, but there is no employment opportunity for us. UHAS, the last I can remember is 2020 batch that has been employed instead of nurses. 2021, 22, 23, 24, and tomorrow we'll be graduating another crop of UHAS graduates and will be released into the world with no job. What suggestion will you give? This one that you are now close to the government. What suggestion would you give in terms of bridging the gap between patient to health worker ratio? Thank you.
This is when you start hoping that the health minister had been around. Because you're talking about a very important issue, a mismatch between the workload and the health workforce. And at a time when people are sort of sitting at home, and it's not just for nurses, it's cuts across. Recently, there's been some feedback also from the Ghana Medical Association about doctors sitting at home. So that whole matter of management of the human resource that we have will have to be looked at again. And it's not just in the cities that you talked about, in the villages as well. I've been in places where you have about 3 midwives in a district with a population of about 80,000. So I know that this is a matter that is of concern to the ministry. I know that they are looking at, it sounds like I'm close to the minister. But yes, it's a matter that is of concern. And they are looking at bringing people on board and recruiting more of the nurses. But we would also have to have a conversation because there is also the lopsided distribution where you have an over-concentration of some of the health workers in certain particular cities. And the matter of posting people outside is often one that has to be linked with the incentive package that goes along with putting people in villages and so on and so forth. So it's a mix of things that I know that is being discussed. On my own, I would not be able to make a specific commitment, but what I can say is that I will take it back into some of those conversations, specifically tell the minister that this is still a matter of concern and it's come up, and as they think through the solutions, they should tackle it. But I know that it is top of mind for the ministry in terms of how all this backlog of nurses. And we're also mindful of some of the promises that were made in the course of the campaign. So yeah, something has got to break. So we'll sort it out from that perspective. But that is really on the table of the minister.
So thank you so much for this opportunity. My name is Bliss. I'm a medical laboratory science student, currently level 300. Yes, so my question is, brilliant delivery. Hello. Okay. So from the brilliant delivery, I think Africa has seen many revolutionary leaders, like the likes of Colonel Gaddafi and even Captain Ibrahim Traore. But what happens in most instances is the fact that the brilliance associated with their leadership seems to end anytime they are not in office. So my question is, how do we create systems that ensures the sustainability of the effectiveness of their leadership and initiatives so Africa can collectively grow like it's supposed to? Thank you.
I think you've put your finger on it. It's really not about the leaders. Professor Stephen Adai said that leadership is cause, everything else is effect. So the leaders are certainly very important. But in improvement science, I would address the first law of improvement, which says that every system is perfectly designed to get the results it gets. So you are right, it's about the system. And if you have the right system, sometimes it's almost as if it doesn't matter who is the leader. It will continue to deliver the results that you've designed it to get. So if mortality is high, it's because your system is designed to get high mortality. If skill delivery is low, it's because that is how your system is designed, whether it is intentional or not intentional. So it's about policies. And some of us learned this the hard way. We did a project in Ghana, formed over 700 quality improvement teams, tested a variety of changes, got improved outcomes, and then realized that once the project ended, a lot of the teams started, getting dismembered, people not working at the same level of intensity, which is why we then managed to get some funding from the Gates Foundation, work with the Ministry of Health to develop a national quality strategy. Because so you get the country itself or the system to own the initiative, and so you implement across the structures, the gains are really not held. Sometimes also the gains cannot be held because you do not actually know what led to the improved outcomes. So in the case of the Burkina Faso example, for one, we would want to ask, what specific things are you doing in your country to make these initiatives possible? It's not just about the flamboyant leader or the charismatic leader, but there are specific changes that are happening. And those are the changes that you want to, the word is hardwire, make a permanent part of your system. Another way in which you can make these things work is to train people so that the knowledge and the expertise do not rest with just one or two people, but you train a number of people that can make things work. There were times when we'll do site visits. We'll go to the hospital and realize that the 3 or 4 people that we trained have all left the facility. Some have married, some have given birth. The data officer is feeling very powerful. He's hiding the data under his armpit. He's gone to the next town. There's nobody to meet. So over time, we realize that you have to train a number of people. And where training is concerned, you also have to recognize that there are different levels for different people. So you have to give targeted capacity building for different categories of staff. The leaders are important, and you have to engage the leaders early, because what you don't want is for the leaders to become a stumbling block just because it's not their initiative and because they're not on board. So again, engaging people appropriately at multiple levels so that they can help. So policy, regulation, capacity building, changing processes, and then also orientation. When you have tested, what we do is that when you've tested changes and the changes have been found to work, you want to document it and you want to make it a permanent part of the way the system works. Next time new nurses come, we no longer want these new nurses to test small cycles of change. We have done the changes, we know what works in our system, it is now policy, this is how we do it going forward. So people come and they are oriented in the new way of doing things, and it becomes business as usual. So there are a number of these strategies that we can employ to make sure that the system itself is strengthened to be able to achieve things, and it is not dependent on one individual per se. But then that is why the psychology of human behavior is very important. Because if you do not find a way in which you can motivate people beyond just money, and let them tap into their own creative skills, it becomes difficult to manage all of these changes. We did a project in Ghana, and we wanted nurses to be able to start some type of treatment at the emergency. And we faced a lot of resistance from the doctors, because they said, well, they are not qualified, they can't do it, they can't start this. It was a lot of back and forth. But we were the ones who had not recognized that the doctor was the leader of the unit. We could not just bypass him and then start dealing with the nurses. So he was resistant. How did we go about it? Sitting down with him, agreeing on the outcome that we wanted, and we said that since you are this super qualified emergency physician, why don't you lead in the training? And that is what made the trick. Once he was the one who was leading and dispensing the knowledge, and we ensured that the training happened, he then became comfortable. So it's also about learning the psyche of the people that we are dealing with, learning to motivate them, using a variety of approaches so that we can get them to fall in line. But thank you for your question.
Okay, I'm not a medical person, but I'm thinking about some of the things that he raised about transforming the health workforce. And I'm wondering whether incorporating management competencies have already been done in the curriculum. Because I'm thinking that these are things that we don't have to, maybe I'm ignorance there, but we don't have to depend on a ministry, the minister, and it can be done at the university level. Do we have management competences being incorporated in the curriculum at this point, or do we intend to do that? Because these are, I think, low-hanging fruits. They are not as complicated, I think. Sorry, I'm Helena Kemeche, just a friend.
All right, thank you very much, Nana. So I'll take the answer, and then I do what I have to do. So yes, all the programs at UHAS, I don't know about other universities, we have management courses in it. It's just that, as you say, the practical components, you are training a doctor. So the MDC has some areas the person must complete, like the nurse. So the management is not as heavy. But this year, we have introduced the health administration program, which is a 4-year degree program. So yes, we have it. So according to the program, the chairperson must give the concluding remarks. But before that, I have a few things to do, even though I know that the time is up. May I humbly ask our new council members to be upstanding for us to recognize them. Please, if you are a council member of UHAS, can you please be on your feet? Chairman and his members, let's give them a hand. We are very happy that you agreed to work with us to move UHAS forward. We thank you so much, and God bless you. Thank you. Please have your seats. I am not doing acknowledgement, but a gentleman introduced himself to me and said he's representing the governor of Bank of Ghana. Sir, am I right? Please come on stage. This auditorium was given to the university by the Bank of Ghana. And because he's here, we want to give him the due recognition. I'll give him the mic to say a sentence. I want to say that you gave us this auditorium, but the money you gave us was not enough. So we didn't finish. So if you see the ambience, it wasn't done. The pavement outside. The pavement outside was also not done. So, sir, this is what you gave us, but you didn't finish the work. You have the right.
All right. Thank you. Thank you. I think my presence here is an indication that the governor is serious about this university and what they intend to do for you. Yes. He would have loved to be here, but other equally important national commitment has taken him somewhere else. So he sent me here. I'll be here today and then tomorrow as well. Thank you. My name is Dr. Said Jibril. I'm the head of the medical department of the Bank of Ghana. Yes, yes. Yes. And I'm actually a patient safety student as well. So I'm quite in line with all the things that my senior mentioned. I met him in the university when he was in final year. Yes. And I think UHAS can take it on patient safety and quality care. There is no such program in the country as at now. And we just train health workers to go out there and take care of diseases, basically. We don't teach them how to take care of human beings. And patient safety is coming on board elsewhere. I think doctors and nurses and institutions being sued is coming on board. Let's take care of our patients. Let's not harm them. Just safe care is enough. And it cannot come just by chance. I mean, if you are not trained to give safe care, you cannot give it. We need that training for healthcare students or workers. Thank you very much.
Thank you, and thank you, because I just put you on the spot. And also, we cannot come here and not even hear the sound of the voice of our council chairman. Chairman, you want to say a sentence before I give my closing remarks?
Thank you very much. My name is Kojo Gahua, and I'm happy to chair the Governing Council of the University of Health and Allied Sciences. I'm very grateful to our keynote speaker today because what touched me is that we must focus on people-centered health care delivery, and that is the most important thing I got from today's lecture. We must be people-centered. It's not just a career development program that we organize here. And then the question about jobs, we don't train people and let them run away to other nations. We have a lot of people to take care of here. And so we'll continue with that advocacy and ensure that the so-called snake-infested university has become one of the leading universities across Africa and the world. Thank you very much.
Thank you, Chairman. So for the sake of those who came late, I want to just reiterate a few things that I picked from the distinguished lecturer today. He started off by chronicling his journey with UHAS from the very beginning. And we want to again thank you for the commitment to service. He emphasized that we need to use evidence to manage conditions, evidence from credible research, and from the interactions that we had with the questionnaires, we have already come across the need for trust, the trust. He emphasized that when donor funding is dwindling or withdrawn, a lot of people lose their jobs, including us, some of our people in Ghana. And we all know repercussions when you don't have a stable job or income. The quotation from our current president, President Mahama, that the next pandemic is a matter of when and not if. is a statement that I don't think I'll forget after this. The fact that the next pandemic will be knocking on our door soon. How ready are we? He also said that there are several things that Ghana has signed, developed policies, but implementation thereof is still a problem. And you and myself, we need to think through how we can implement policies and other things that we sign up to. The human resource shortage was emphasized, but the good news is that we have snake venom antiserum ready to be manufactured in large quantities. And the fact that they are going to work with us at UHAS to be part of the story of vaccine development in Ghana. The issue about poor quality contributing to over 50% of death is scary. And so because we train health professionals and we are within the health space, we need to take this seriously and make sure that we deliver quality service. There are several others I could allude to, but because of time, I want to end by saying that President Evans Fifi, John Evans Fifi Atta-Mills, believed in young people. And so he gave him the opportunity to serve in the highest decision-making body of the university at a very young age, and he gave other examples. However, he said that leaders must be strong but humble, and that is an embodiment of our late president, John Evans Atta-Mills. So on this note, today I meet you, I'll give you a summary. Unfortunately, we are out of time. So we want to say a huge thank you to the lecturer. In fact, when he started and he got to the vaccine, I thought he was going to end. But then he took us to different levels, and you and I will go back. The link, YouTube link, is shared. Go and listen to it again and again and pick life lessons. Thank you very much, and God bless us all.
Thank you very much, Prof. May I call on Director of Public Affairs, Mr. Anthony Asempa, to do us the acknowledgments. Earlier on, I forgot to tell you that Professor John Jinapo sent a representative from the Ghana Tertiary Education Commission in the person of Professor Augustine Oklu. Prof. Oklu, give us a wave. Toby, please.
Thank you, Madam. Good afternoon. All too soon, we are coming to the end of the program, and we would like to acknowledge a few people on paper, but all of us here, we acknowledge your presence. We are grateful and we are pleased that you have been able to make it this afternoon, and we hope you continue to patronize UHAS programs. With us, we have Professor Kojo Gavua, who has already been introduced, but I would like to introduce him again. He's our new council chair, Professor Gavua. Then we have Professor Kofi Anyidoho, who made sure that UHAS students are able to learn their home culture in addition to medical profession. We acknowledge the presence of Professor Kofi Anyidoho. We have our Foundation Vice Chancellor. If we have Buffalo soldiers, I think he will be called Buffalo Soldier. That's Prof. Emeritus Professor Fred Newton Pinker, we acknowledge your presence. Yes. Dr. Said Jibril from Bank of Ghana, we once again acknowledge your presence. We have Professor Seth Osu Ajay, former Pro-Vice Chancellor of UHAS. You are duly acknowledged. Then we heard him. He was able to ask a question to the lecturer and also a person who is not the lecturer, Dr. Mark Amaho, former council member. We acknowledge your presence. Our honorable MP of this constituency, Mr. Adam Potosu, you are welcome. Honorable Potosu. Then we have Honorable Ludwig Hollinger, the director for Atta-Mills Institute, Atta-Mills Heritage. You are duly acknowledged. We have regional executives and members of the ruling NDC party present. Your presence is duly acknowledged. You are welcome. We are happy to have you around. Togbe Fiankoku, the paramount chief of Sokode and his entourage, we duly acknowledge your presence. Na Adoko Soji Tete, Family Health University, we acknowledge your presence. Then we have friends and family of Dr. Soji Tete. You are all duly acknowledged. Deans, directors, faculty, staff, and students of UHAS here in present, we duly acknowledge all of you here. Thank you for making it. We also have tutors and students from the whole nursing training college. We thank you. We are pleased you are with us. And all those who played roles in making sure that this program has been a success, the ICT team, the works team, the protocol, and all others who played roles to make sure that this program has been a success. We thank you, and we are pleased that you played your roles, and we continue to be grateful. We have a few announcements. From here, we will meet at the council chamber, that's the SBBS council chamber, for the council members and guests for a few interaction. Then, for the lecturers and staff of UHAS, will meet at lecture room 6, SBBS lecture room 6. Other guests and students will wait in here for a brief interaction. Thank you all. May God bless us all.
Toby was not here when the choir sang, so he didn't acknowledge the choir. Choir, I acknowledge you duly. And with that acknowledgement, you'll be doing the UHAS anthem for us. Shall we please be upstanding whilst we do the UHAS anthem? Alhaji Nuruddin, get ready after the anthem. You'll give us a closing prayer. Take a photograph together.
Shall we pray? In the name of Allah, the most beneficent, the most merciful. Allah, we thank you for this afternoon's program. We started this program in your name, and you've been with us throughout, and we are ending with us successfully. Allah, we thank you for the lives of the university community. We thank you for the lives of the governing board. We thank you for the lives of the faculty and staff and our students at large. As we gathered here today, you've been with us. And we know we are going to bring us here safely tomorrow to continue our program. We thank you for an answered prayer. Amen.
Those at the back, kindly come down so that we take a group photograph downstairs. My Lord Chair, please, we'll go down. I remember calling my Lord Chair, so Professor Gabo.
The books. My chest.
My chest. Pause. My chest.
I don't know why. That boy is now. Your captain fighting.
Students, kindly remain seated.